Assalamu alaikum, my dear seniors and colleagues. My name is Aslam. I am currently working as a resident and this topic will cover the epidemiology and the mechanism of cervical spine in sports injuries, classify the sports cord injury type 1 to type 3 spectrum, and the cervical cord, neuropraxia, stingers, and burning hands, vascular injuries such as carotid and vertebral artery injuries, and spare tackle, spine, and football specific risk, pre participation, and return to play guidelines. So, in this diagram, the overall there is a risk of 7.8 to 15% sports related spinal cord injuries, and there is 1.3 to 6% cases of the cord neoplasia per 10,000 athletes, especially the football players. There are 48% spinal cord injuries seen in road traffic accidents, and 21% in fall from height, and 15% in sports injuries, and 13% cases are reported such as in case of violence. So, in order to understand the sports injuries that cause the cervical spine damage and cervical spinal cord damage, we should know the applied anatomy of the cervical spine. So, it plays a dual role, such as in mobile support for the head and the protective conduit for the cord and nerve roots. It uh, provide the space for the card. So the cards reserved within the canal is the key protective factor. Vertebral artery, it ascends through the foramen transverse area from C6 to C1, and it is vulnerable to injuries in the fractures that traverse the transverse foramen, and called somatotopy. Corticospinal tract is laminated. Hand and arm fibers are medial one, while the leg fibers are the lateral. So next, please. So the mechanism of the injury, it starts with the axial loading. The vertex on the impact of the vertex, the axial load on the crown of the head, that will lead to the neck flexion at 30 degree, and the normal lordosis of the cervical spine has been lost. So the the spine becomes rigid and segmented column. The protective neck muscles are bypassed because the normal lordotic curvature of the cervical spine has been lost due to the axial loading, and the energy directly transfers to the bone, ligaments, and intervertebral discs, that will result in the fracture of the vertebra or dislocation or and cord injury. So the injury vectors are axial compression that will lead. There are the four mechanisms through which the injury occurs: axial compression, hyperflexion, hyperextension, and rotation. So the classification of the cord injury, basically the sports cervical cord injury results in the reversible and irreversible injury. The reversible injury include the stinger, burner, and the cervical cord neuropraxia, transient that is the transient quadriplegia, to central cord syndrome, and the burning hand syndrome. While the irreversible cervical cord injury includes the complete or incomplete spinal cord injury, fracture dislocation, and sciura, especially in the pediatric population. So, the types of the cervical spinal cord injury: type 1 is a complete and incomplete spinal cord injury. So in this, there are the clinical manifestation of the injury in the patient along with the radiographic changes. And type 2 is a transient neurological symptoms. Patient presents with the transient neurological symptoms while the radiographic imagings are the normal. While the type 3, there is no neurological symptom in the patient, but there are radiological abnormalities on the imaging, such as fracture, compressed fracture, or burst fracture, or the dislocation, or ligamentous injury, or intervertebral disc herniation. So these are the basically main three types of the cervical spine injuries. Type 1 is the complete and incomplete along with the radiological manifestation of the injury. Type 2 is the transient neurological symptoms and the radiology is normal. While the type 3, there are no symptoms in the patient while there are findings in the imaging. So cervical cord neuropraxia. It is a transient, fully reversible cord dysfunction from compressive deformation, bilateral sensory and motor symptoms in arms and legs. Usually less than 15 minutes cut, it remains for less than 15 minutes, but it can stay up to 48 hours and 5 days in children. It can result in the complete paralysis and motor weakness and sensory changes. There are three grades. That is the top grade based on the duration of the symptoms. If the symptoms are transient and uh, reverse within 15 minutes, then it is a grade 1 injury. If the symptom persists from 15 to 24 hours, then it is a grade 2 injury. And if the symptoms persist greater than 24 hours, then it is a grade 3 injury. So uh, after the cervical cord neuropraxia, the stingers and burners. These are basically the most common sports cervical sports injuries and cervical spine. Uh, it will result in the transient and unilateral burning or tingling sensation along with a weakness in one arm. So the main point is it is transient and it is unilateral, not the bilateral. In the burning hand syndrome, the symptoms are bilateral, while in the stingers and burners, the symptoms are unilateral and these are transient. So the mechanism is there is a traction on the plexus, such as brachial plexus. There is a compression of the roots or the foraminal compression or the direct blow to the Albs point, the upper trunk of the cervical cord C5, C6. And the pattern is the upper trunk C5, C6 that resolves in seconds to minutes. And the chronic burners, if a patient is a sportsman and it has already multiple episodes of the injuries that result into the burners, recurrent stingers in older athletes, that will lead to the foraminal root compression. Next, please. It is the mechanism of the injury in stringers and the burner. So first of all, there is the traction injury. As a result of the traction injury, there will be the lateral flexion of the head with the depression of the shoulder that stretches the upper trunk of the brachial plexus, the Albs point, the C5, C6. So the lateral flexion will lead to the depression of the shoulder and stretch on the upper trunk of the brachial plexus. And the second one is the compression injury. If there is a blow to the supraclavicular region that forces lateral flexion and the rotation extension of the neck away from the impact, it will cause the impingement of the extremal root. Burning hand syndrome. Burning hand syndrome manifests with the symptoms bilaterally in both hands, tingling sensation and the burning sensation, while it is a mild form of the central cord syndrome. Centrally located hand fibers of the corticospinal tract are hit first. So why it matters? Because how can we differentiate the burning hand syndrome from the stinger? In the stinger, the symptoms are unilateral, while in the burning hand syndrome, there are the bilateral symptoms. So the management is work up as a spinal cord injury, and return to the practice is typically contraindicated until the fully evaluated and patient has been recovered in the uh, burning hand syndrome. So the vascular injury, the main vessels that are encountered in the cervical spine injuries are the carotid and the vertebral arteries. So the vertebral artery, nearly all injuries accompany subluxation or fracture through the foramen transversarium, because the artery ascends from C1 to C6. If there is a transverse fracture of the foramen transversarium, then it will lead to the injury of the vertebral artery. And carotid artery, if the mechanism of the injury is a hyperextension with contralateral rotation, it will lead to the injury of the internal carotid arteries. And there is a criteria depending upon the condition of the patient, uh, for which patient we will consider the vascular injury, and how we can grade it. If the patient is having a thromboembolic phenomena, such as a patient with a cervical spine injury, and after the injury the patient has weakness, and in CT there is a ischemic changes, the thromboembolism, then we can order the investigations. And the Biffle Denver grading of the vertebral injuries is grade 1 to grade 4. In grade 1, there is less than 25% foraminal stenosis, and in grade 2, there is greater than 25% luminal stenosis of the artery. While in grade 3, there is the formation of the pseudoaneurysm, and grade 4, there is a complete occlusion of the lumen of the artery. And in grade 3, there is a complete occlusion of the lumen of the artery, while the grade 4, there is a transection of the artery totally. So the clinical clue, a patient will present with neck pain and delayed or fluctuating deficit or Horner syndrome. If the patient with a cervical spine injury and there are the clinical signs and symptoms of the Horner syndrome, then we can suspect that there is a vascular injury, and we can manage the patient accordingly. So the axial load and the spare tackling. Basically, in this, the head first tackling with the vertex of the helmet as the first point of the contact. Whenever the external force is being applied in the trauma, so that will lead to the loss of the cervical lordosis and the straightening of the cervical spine. That will lead to the directly loading of the force on the vertebra, and the intervertebral space has been reduced. And so we can see in the picture, there is the intervertebral space has been reduced, and the normal lordotic curve has been lost, due to which it can lead to the traumatic disc herniation or the fractures of the vertebra. Next. So basically, it is a mechanism of the injury. The impact from the vertex traveling go through the downward. The space has been decreased, and as the space has been decreased, there is a straightening of the cervical curvature, and that will lead to the fracture of the vertebral body. We can see in the picture D, and dislocation as well. So spare tackler spine. Radiographic data identifying the athletes at the highest risk of catastrophic injury. Basically, there are four main criteria. It will lead to the development of the cervical canal stenosis, loss of the cervical lordosis, and pre-existing bony injury. And fourth one is the spare tackling technique. So it is a comparison. This is a picture that is showing that there is a hyper intense signal in the MRI of the patient. Is the T2 weighted images, and there is a hyper intense signal at the level of the C4 and C5. Uh, and after the treatment with the conservative treatment, after 8 months, in the next diagram B, there is no hyperintense intense signals at the level of the C4 and C5. And uh, and there is a next one diagram that is depicting that patient in a cervical sport injury, that is a traumatic disc herniation at the level of C3 and C4, and the patient has been treated, and then the herniated disc was removed. Pre-participation evaluation. So basically, the three main things are very important in this: history, examination, and imaging. So in history, we will ask from the patient, is there any prior history of the stinger or transient quadriplegia, or there is any congenital anomaly such as clipal field or carry malformation or os odonti, and on examination, full pain, painless cervical range of motion, normal strength, and no long track signs. Basically, these criteria will help out us to advise the sportsmen back to normal training. And imaging, uh, there is a neutral flexion extension radiographs, MRI of the spinal cord, and functional reserve. So here the torque ratio is very important. If the torque ratio is less than zero point 0.8, then the sportsmen are not advised back to practice. If it is greater than or equal to zero point 0.8, then they are advised for the back to practice and continue in a normal routine. Next, please. So return to play framework. What are the absolute, relative, and contra indications? The absolute contra indications are there is a spare tackle spine instability, and cord signal changes or persistent deficit in the patient. The relative indications are these are individualized, and if there are greater than three stingers or the symptoms that persist more than 24 hours, and there is a uh, prior cervical spine cord injury with full recovery. These are the relative indications. The no contraindications are if there is a single stinger and the patient has been fully recovered or healed stable single level pathology. Next, please. Back. And bony or ligamentous instability, spare tackles, spine, symptomatic disc herniation or cord signal, the persistent neurological deficits and myelopathy, Arnold Chiari malformation or odont, odontidium, odontidium, and multi-level such as 2 or 3 level cervical fusion. The relative contraindications are prior cervical cord injury with full recovery, single level fusion, and recurrent stingers, and asymptomatic stenosis, no cord deformation, and healed disc herniation, and the patient is neurologically intact. So this was all about today's topic discussion. If you have any queries.
It was a very good presentation, very extensive, but I have few questions. Can you please again explain briefly explain the cervical cord neuropraxia?
Sorry.
Cervical cord neuropraxia.
Cervical cord neuropraxia, basically these are the sensory or the motor symptoms in the patient. It can cause paralysis, sensory disturbance, complete or incomplete paralysis in the patient, and the weakness of the motor power up in the patient,
And how it is different from other cervical cord injuries?
such as stingers. And ba- basically there are three type of injuries: neopraxia, stingers, and uh, burning hand syndrome. While the stingers have unilateral symptoms, there is a sensation of tingling and burning sensation, but the burning hand syndrome has a bilateral symptoms. Are you getting my point? And in these stingers and the burning hand syndrome, only the sensory system is involved, while in neuropraxia, sensory and motor system both are involved.
स्टिंगर बर्नर्स में ना वो वीकनेस भी आ सकती है।
Okay.
आ सकती है। बेसिक मैकेनिज्म का फ़र्क है ना इनमें। मैकेनिज्म क्या है इसका, सर्वाइकल कॉर्ड न्यूरोप्लेक्सिया का, ये क्यों होती है? वो स्टिंगर बर्नर्स का आपने बता दिया, कंप्रेशन ब्रेकियल प्लेक्सिस की हो सकती है, ट्रैक्शन हो सकती है। और बर्निंग एंड में सेंट्रल कॉर्ड जो है वो होता है। और इसमें सर्वाइकल कॉर्ड न्यूरोप्लेक्सिया में क्या होगा? होती है। लेकिन मुझे लगता है ये ट्रांजिएंट सिम्टम्स होते हैं ना, ये यूजुअली रिजॉल्व हो जाते हैं। तो इनमें हो सकता है कि स्पाइनल कॉर्ड के अंदर कोई एडिमेटस चेंजेस हो सकती हैं, जिसकी वजह से वो ट्रांजिएंट सिम्टम आते हैं, और जैसे
Concussion
एडिमा रिजॉल्व
injuries.
होता है तो वो सिम्टम्स रिलीफ हो जाते हैं।
ये न्यूरोप्लेक्सिया में आप कह
जी
रहे हैं।
सर।
इसी तरह ये जो आपकी पेरिफेरल नर्व्स होती हैं ना, वो भी बेसिकली जस्ट लाइक स्पाइनल कॉर्ड ही है। तो उसमें भी जो इंजरी है ना, उसके 3 ग्रेड्स हैं ना। इसमें जो सबसे माइनर है वो न्यूरोप्लेक्सिया है, फिर उसके बाद एक्सोनेटोमेसिस है, फिर न्यूरोटोमेसिस है। तो ये जो न्यूरोप्लेक्सिया है ना, ये ट्रांजिएंट है, और मोस्टली ये शेयरिंग स्ट्रेस की वजह से, अगर कोई नर्व पे या कार्ड पे ट्रैक्शन है तो उसकी वजह से कोई माइक्रोस्कोपिक लेवल के ऊपर इंजरीज होती हैं, जो विद पैसेज ऑफ टाइम रिजॉल्व हो जाती हैं। लेकिन जो एक्सोनेटोमेसिस है या न्यूरोटोमेसिस है, उसमें टाइम लगता है। मॉडरेट जो है वो एक्सोनेटोमेसिस है, और जो सीवियर है वो न्यूरोटोमेसिस है। एक्सोनेटोमेसिस में भी 2 टाइप्स हैं, उसका ग्रेड 1 है, ग्रेड 2 है। ग्रेड 1 की रिकवरी बेटर है, तकरीबन 2-3 माह में रिकवरी हो जाती है। लेकिन जो ग्रेड 2 है उसमें रिकवरी कम होती है, और जो न्यूरोटोमेसिस है उसमें रिकवरी के चांसेस नहीं होते। ये जो अक्सर हमारे पास पेशेंट आते हैं ना, जिनको इंजेक्शन की वजह से कोई वीकनेस आती है, और उनका हम एनसीए करवाते हैं, तो उसमें ये फाइंडिंग आपको मिलती है। न्यूरोप्लेक्सिया है, एक्सोनेटोमेसिस है, ग्रेड 1 है, 2 है, या न्यूरोटोमेसिस है।